Welcome back to part 6 of the 150-part IPDRG masterclass on Decode Healthcare with Harshal. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, so in today's explainer, we're diving straight into secondary diagnoses. Honestly, this is a totally vital piece of the whole inpatient coding puzzle, so let's get right into it. But real quick, before we tackle today's complex logic, let's do a rapid recap of Part 5. You remember the principal diagnosis, right? That's the condition established after study to be chiefly responsible for occasioning the admission. It's basically the heart of the inpatient account, and it determines our major diagnostic category. But let's be real, patients rarely come in with just one straightforward problem. And that is exactly why today's lesson is absolutely crucial. Here is what we're covering today. First, defining secondary diagnoses. Then, the 5 reporting criteria. After that, understanding CCs versus MCCs. Next, DRG impact, followed by chronic and history conditions, and finally, a summary and a teaser for Part 7. Let's contour this. Section 1. Defining secondary diagnoses. So, what exactly is a secondary diagnosis? Well, according to the USHDDS, these are all the conditions that either coexist at the time of admission, develop subsequently, or affect the treatment received. Simply put, these are the extra diagnoses sitting right alongside your principal diagnosis, and they actively impact the patient's care. If the principal diagnosis is the star of the show, you can think of the secondary diagnoses as the essential supporting cast. Now, a really interesting distinction we have to make here is between 2 major types of secondary diagnoses: comorbidities and complications. A comorbidity, that's a condition the patient already has when they walk through the hospital doors. Think of someone admitted for pneumonia who also happens to have chronic diabetes. A complication, on the other hand, is something that arises during the hospital stay itself, like, say, a postoperative infection or maybe an acute kidney injury that suddenly develops on day 3. Both are super important to capture, but their origins on the timeline are completely different. Section 2, the 5 reporting criteria. Okay, so the UHDDS gives us a strict, mandatory rulebook. To legally report a secondary condition, it has to affect patient care by requiring at least one of these 5 things. Number 1, clinical evaluation, like diagnostic lab tests or imaging. Number 2, therapeutic treatment, like prescription meds or specialized therapies. 3, diagnostic procedures, think biopsies or scopes. 4, an extended length of hospital stay. Or number 5, increased nursing care or monitoring. The big takeaway here is this: if a documented condition doesn't meet at least one of these 5 criteria during the stay, you do not code it, period. Let's see how this actually plays out in the real world. On a typical inpatient face sheet, right below a principal diagnosis of, say, acute pyelonephritis, you'll often spot a secondary diagnosis like dehydration. Now, the dehydration wasn't the main reason they were admitted, right? But it very likely required IV fluids, which fulfills our therapeutic treatment criterion. Boom, it legally qualifies to be coded. Section 3. Understanding CCs versus MCCs. You might be wondering, why do we care so much about these extra codes? Well, it all comes down to 2 incredibly powerful acronyms, CC and MCC. A CC, which stands for complication and comorbidity, is a secondary diagnosis that adds moderate severity to a case, but an MCC, a major complication and comorbidity, that represents a highly significant diagnosis that demands a substantial increase in hospital resources. Tracking down and properly documenting an MCC is honestly one of the most critical functions of an inpatient coder and a CDI specialist. Let's look at a quick comparison to really grasp the difference here. Common CCs include stuff like mild malnutrition, chronic atrial fibrillation, or a simple UTI. They definitely increase care needs, but moderately. Now look at the MCCs: acute renal failure, septic shock, acute respiratory failure. These are life-threatening, system-wide emergencies. They drastically escalate the complexity, the risk of mortality, and of course, the cost of care. The severity difference is stark, and the coding system is designed to recognize that. Section 4, DRG impact. The MSDRG system heavily rewards accurate coding. Think of the DRG triplet structure almost like a 3-tier podium. Down at the bottom, without CC/MCC, yields the lowest relative weight and the lowest payment. In the middle, with CC, gives a mid-range payment. And up at the top tier, with MCC, results in the highest payment, because it has the highest relative weight. So your accurate coding of secondary diagnoses literally determines which tier the hospital lands on for that patient's stay. No pressure, right? Let's apply this to a specific pneumonia case study from our source material. Say a patient just has simple pneumonia. They sit right at the base DRG weight. But if you add a secondary diagnosis of type 2 diabetes with complications, which is a CC, the relative weight jumps up, leading to moderate reimbursement. Now, if that exact same pneumonia patient develops septic shock, an MCC, you hit the maximum relative weight. One single, highly specific secondary diagnosis changes the entire financial outcome of the case to accurately reflect the massive resources the hospital spent trying to save that patient's life.
Section 5, Chronic and History Conditions.
Okay, so I hear this question all the time from students. Do we code a patient's personal or family history? For instance, if a patient is admitted for acute bronchitis, but they have a family history of lung cancer, do we go ahead and code the cancer history?
Well, the short answer is yes, you can, but with a pretty major caveat. Personal or family history codes, like Z80 for family history of cancer, are absolutely permitted if they're clinically relevant to the current stay. However, the crucial thing to remember is that they do not impact the DRG assignment, and they won't increase reimbursement. They are fantastic for painting a complete clinical picture for the doctors, but they aren't going to shift your DRG tier into a higher payment bracket.
Chronic active conditions, on the other hand, completely different story. Conditions like hypertension, diabetes, or COPD absolutely must be coded if they're medically managed during the stay. If a patient is admitted for a broken leg, but the nurses are giving them their daily blood pressure meds or checking their blood sugar, that counts as therapeutic treatment and increased nursing monitoring. You've hit the criteria. These chronic conditions very often act as CCs, and they definitely impact the final DRG. So whatever you do not leave them off the claim.
Section 6, Summary and Teaser. Let's wrap up this explainer and look at what's next.
Here are your top 3 takeaways to apply to real patient charts today. 1. A secondary diagnosis must meet at least one of the 5 reporting criteria, like clinical evaluation, treatment, or increased nursing care. 2. CCs and MCCs are the severity engines that drive MSDRG tiers and ensure fair hospital reimbursement. And 3. Never ignore chronic conditions. If they're actively managed with routine meds or monitoring during the stay, they absolutely must be coded.
So, you've mastered the rules for secondary diagnoses, but what happens when the ICD-10-CM book gives you conflicting instructions? Next time, in Part 7, we're tackling the complex logic of ICD-10-CM inpatient conventions. Excludes 1, excludes 2, code first, and use additional code. It's going to be a fascinating deep dive that'll keep you hooked on proper coding guidelines. But before we go, consider this. How much revenue and how much accurate severity data is lost every single day simply because a chronic condition wasn't properly documented as being managed by a nurse? It's a huge responsibility we carry to make sure the chart tells the whole story. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I will see you in Part 7.